Okay, so now we are going to discuss gallbladder cancer and pseudomembranous colitis. Diabetic patient underwent cholecystectomy and developed surgical site infection. Histopathology revealed CA gallbladder. What is the most commonest type of malignant neoplasm of the gallbladder? Adenocarcinoma 95%, squamous cell carcinoma 5%, adenosquamous differentiation less than 1%. So adenocarcinoma is the most common type of cancer in gallbladder. Cause of gallbladder cancer. The most common cause is colitis, gallstones, and chronic cholecystitis, porcelain gallbladder, and the gallbladder polyp greater than 1 centimeter, and so genetic factors. So these are the cause. What are the risk factors? Age greater than 70 years, female sex, and family history, ethnicity, Mexican, Native Americans, smoking, gallstone, most common. Gallbladder polyp greater than 1 centimeter, porcelain gallbladder, as we already said. So, chronic infection by staph salmonella typhus, yes, and choledochal cyst, obesity, and yeah. So, okay, so let me tell you something about porcelain gallbladder. In porcelain gallbladder, lab coli is contraindicated. Why? Because it can, if let's suppose if you did laparoscopic cholecystectomy for porcelain gallbladder, so if there is a CA, there is a high chance that it will infect this margin of the trocar side. So there is a risk of seeding into the anti-abdominal wall. So be careful in porcelain gallbladder. Laparoscopic cholecystectomy is contraindicated. You have to do open cholecystectomy. What? Open cholecystectomy. Okay, so what does gallbladder cancer spread first? Or sorry, where does gallbladder cancer spread first? A direct invasion to liver, segment 4 and 5. To be very specific, segment 4B and 5. Okay, so other sites to spread: porta, hepatis, lymph nodes. Okay, CBD, the stomach, and first part of duodenum. So these are the surrounding neighboring structures. Very simple. SSI in surgical site infection in post-op day 3 with yellowish and smelly discharge. What is the cause? So this is making a problem for me. Okay, so surgical site infection post-op day 3 with yellowish and smelly discharge causes local sepsis, most likely due to bacterial. What is the most common organism causes surgical site infection? It is Staph aureus, because it is in the skin, normal flora of skin. So that's why it will cause. The patient condition deteriorated by pyrexia, tachycardia, decreased urine output, local tissue has a intense congestion and focally discoloration with visible necrotic tissue. What happened? Necrotizing fasciitis. Causative organism. Group A beta, Group A Streptococcus, Staphylococcus aureus, Clostridium difficile, Bacteroid fragilis, and Vibrio vulnificus. In this case, with minimal inflammation and low local cellulitis, what will you do? With the minimal inflammation and no local cellulitis, what will you do? 4 things. Open the wound and take a swab. Clean the wound, allow drainage, take bacteriological samples. So, in such cases, you have to open the wound and take the swab. Clean the wound, allow drainage, and take bacteriological samples. How will you diagnose necrotizing fasciitis? So there will be cellulitis, crepitus, laboratory, LRINEC, laboratory risk indicator for necrotizing fasciitis. Laboratory risk indicator for necrotizing fasciitis. So this is a score. So score greater than 6, necrotizing fasciitis is highly considered. Okay, so this is score. I will share its picture in the WhatsApp channel. Okay, so it's here, we can discuss it here as well. So the CRP is greater than 15 milligram per deciliter, 150 milligram per liter. It will give you 4 pints. WBC 10,000, or less than 15, no value. Less than 15, no value. 15 to 25, 1. Greater than 25, 2. And greater than 13.5, hemoglobin greater than 13.5, so it will no value. 11 to 13.5, as it decreasing, it will raise the value, so 1. And less than 11, 2. Sodium less than 135, normal is 135 to 145. This is a normal value of sodium. This is also a station question at one station. So the normal value is 135 to 145, so less than 135 is 2. Creatinine greater than 141 micromole per liter or greater than 1.6 milligram per deciliter. It's also like 0.1 to 1.2 or 1.1. So 1.6 milligram per deciliter will give you 2 points. Greater than 180 milligram per deciliter glucose will give you 1 point. So this is the laboratory risk indicator for necrotizing fasciitis. I will also share the picture. What is the basic pathology of necrotizing fasciitis? Extensive necrosis with thrombosis of blood vessels. Management. Hemodynamic support. Always, necrotizing fasciitis is an emergency, surgical emergency. So always according to CRISP protocol. So ABC and then hemodynamic. In C, you have the hemodynamic support according to CRISP protocol. Surgical deployment of dead and infected tissue till viable tissue appears. Antibiotics according to culture and sensitivity. Before that, empirical broad spectrum antibiotics should be commenced according to the trust protocol. Surgical dressing. Who to involve in care? Intensive therapy unit specialist, general surgeon, and plastic surgeon should be involved. Patient is on broad spectrum antibiotic post-operatively to treat surgical site infection and develop abdominal pain. On post-operative day 5, sigmoidoscopy was done, which shows to you. Okay, so this is sigmoidoscopy of the patient. What do you see in this sigmoidoscopy? Yellowish plaques with inflamed mucosa in between, which indicates patient has pseudomembranous colitis because patient received broad spectrum antibiotic for 5 days. So these are the yellow plaques with intermingled in between the inflamed tissue. So what is this? This is pseudomembranous colitis because he has used antibiotics for 5 days. Signs and symptoms of pseudomembranous colitis: abdominal pain, bloody diarrhea. Patient will be hospitalized and will be on broad spectrum antibiotic. There are some specific antibiotics which causes this. What are the blamed causes of pseudomembranous colitis? Prolonged antibiotics, healthcare workers, and hand hygiene. Okay. Only one test to detect pseudomembranous colitis formed by Clostridium, colonoscopy. How to confirm pseudomembranous colitis? So colonoscopy, full blood count, ELISA for toxin, PCR for Clostridium difficile, immunoassay for glutamate dehydrogenase, abdominal X-ray can show toxic megacolon. Patient responds to treatment and is improving, but 9 days later patient develops bloody diarrhea. Mention 4 differential diagnoses for that. Pseudomembranous colitis, ischemic colitis, hospital-acquired infective gastroenteritis, norovirus, inflammatory bowel disease. Okay, it can be pseudomembranous colitis, ischemic colitis, hospital-acquired infective gastroenteritis, norovirus, and inflammatory bowel disease. Pathogenesis of pseudomembranous colitis. After broad-spectrum antibiotic introduction, kills normal flora, promotes growth of Clostridium difficile, secrete exotoxin, damage bowel mucosa, exudation of protein and inflammatory cells. Alternatively, pseudomembranous colitis is often triggered by antibiotic therapy that disrupts the normal microbiota and allows Clostridium difficile to colonize and grow. The organism releases toxins that disrupt the epithelial function. The associated inflammatory response includes characteristics volcano-like eruptions. Uh, so this so this a bug will disrupt the epithelial function, and in response there will be inflammation in a form of volcano-like eruptions of neutrophils from the colonic crypts that spread to form mucopurulent pseudomembranes that will form mucopurulent pseudomembranes. So what is the treatment? Consult with microbiologist and treat according to the latest guidelines. If WBC is less than 15,000 or creatinine less than 1.5, oral vancomycin 125 is the first line drug. QID for 10 days or fedoxomycin, this is the second line according to NICE guidelines, 200 mg BD for 10 days. So your first drug is oral vancomycin 125 mg QID for 10 days or fedoxomycin 200 mg BD for 10 days. If both agents are unavailable, then oral metronidazole 500 mg TDS for 10 days. Okay. Severe WBC greater than 15,000 or creatinine greater than 1.5. Oral vancomycin 125 QID for 10 days or fedoxomycin 200 mg BD for 10 days. Fulminant causes hypotension, shock, ileus, megacolon. Vancomycin 500 mg QID by oral or NG tube if ileus, consider rectal instillation plus IV metronidazole 500 mg 8 hourly. Okay, 8 hourly. If no response, go for colectomy with externalization of bowel. So look at this fulminant management vancomycin 500 mg QID by oral or NG tube. Why not IV? Vancomycin is never given IV because it will not diffuse into the gut lumen. So that's why. So this is a diagrammatic representation of the clostridium. Clostridium will attack this, and this will then leads to the inflammation, and inflammation will cause eruptions of neutrophils in the form of pseudomembrane, abscesses from crypts, and this will cause Clostridium difficile. So okay,